Hello, good evening, everyone. Hello, I'm Paul Cairns. I'm the head of computer science, and it's my real pleasure to welcome you here this evening to the inaugural lecture of Professor Ibrahim Habli, particularly as you've come out on what's a rather parky evening. So it's quite chilly in here, so I'm hoping we'll get excited and we'll generate some heat to get things going here. So that's on you, Ibrahim. Ibrahim has been a long time in the department. He joined the department in 2003 as an MSc student, which is where I presume he first really got into safety and safety engineering, more or less.
Maybe arguments.
Okay, safety arguments. He briefly left in a misguided attempt to go somewhere else, but was tempted back to the university by Tim Kelly, who is really nice to see here, Tim, to do a PhD. And at that point, he was thoroughly hooked in and became an RA, working in various roles, teaching on the safety program, which still flourishes in the department, before eventually becoming a lecturer, and then very shortly afterwards a senior lecturer, and very shortly after that a reader. He spent a whole year as a reader before he became a professor, and he didn't even spend a whole year as a professor before he became Director of Research for the Assuring Autonomy International Programme, which is now becoming the Centre for Assuring Autonomy, one of the largest projects in the university, and certainly the largest project in the country, arguably the world, looking at the safety of autonomous systems, which, as you can imagine, is quite an important topic in current times. Added to that, he's also become the director for the new Centre for Doctoral Training in SAINTS. I can't remember what it stands for, but it's about safe AI, which is the first three letters, I assume. Which is an amazing thing for the university, because that'll be 60 and probably more by the time Ibrahim's finished PhD students over the next 5 years, all to becoming experts in the area of safe autonomy and safe AI. And again, the importance of that cannot be understated. So I've said enough to hopefully embarrass Ibrahim a little bit with his success, but I'll leave him therefore to tell you the more interesting stuff about what he's been doing and why he's got here. So please welcome Ibrahim.
Okay, thank you, Paul, for the nice introduction and kind words. And thank you, everyone, for making it today, a Wednesday evening in December. Where else to be but in a lecture room, listening to me talking about how safe or unsafe AI is for your health. I really don't need to spend too much time motivating the topic. AI is everywhere and is increasingly being integrated to many aspects of our lives. If you drove here today and you have a new car, possibly AI is part of your car, possibly for object detection. And if you check Google Maps for directions, that's an impressive piece of AI that many of us depend on these days. And AI is seen as a key technology to help us address some of the grand challenges we're facing. And healthcare seems to top that list. And there isn't a shortage of headlines to do with AI, in particular, telling us how good AI is compared to the poor human clinician. So let's take one example. It is from The Guardian, from back in October, where the headline says, ChatGPT might be better than GP, general practitioners, at following depression guidelines study. Which is good, and the practice-oriented person in me would say, can you start using it and help ease pressure on GP surgeries and services? The answer is, read the font in smaller sizes. It said further work was needed to examine the risks and ethical issues arising from AI's use. But you've just said that it's the answer. If you keep reading, it says AI should never be a substitute for human clinical judgment in diagnosing and treating depression. But the headline has just undermined the human clinician in terms of how good AI is compared to them. Unfortunately, this is not an uncommon story. Big headlines, but serious caveats. And one of the fields where AI is impressive, and don't get me wrong, AI is a powerful and impressive technology. And it's going to help us deal with many global health challenges to do with aging populations and inadequate access to healthcare in many parts of the world. And one of the areas where AI is producing impressive results is radiology. So let's listen to what Geoffrey Hinton, one of the godfathers of AI, had to say about radiology in particular. Let's see whether YouTube works here.
Come.
Let me tell you who Geoffrey Hinton is. He's, again, as I said, one of the godfathers of AI, and he specializes in one technique called deep learning. And he's one of the most cited scientists in the world. This is 2016, telling us more about AI in healthcare.
Sorry. Let me start by just saying a few things that seem obvious. I think if you work as a radiologist, you're like the coyote that's already over the edge of the cliff, but hasn't yet looked down, so doesn't realize there's no ground underneath him. People should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do better than radiologists, because it's going to be able to get a lot more experience. It might be 10 years, but we've got plenty of radiologists already. I said this at a hospital, and it didn't go down too well, but they did.
So that was in 2016. The guy, with the usual sense of confidence you get from AI researchers, said, stop wasting your time and stop training radiologists. 7 years ago. Earlier this year, we have this headline from The Guardian, again. I'll have other newspapers represented more on the right side of politics, so don't worry about it. So that's the headline from The Guardian, saying, cancer patients face life-threatening delays due to lack of staff, say UK radiologists. And luckily and thankfully, no one took his comments seriously 7 years ago, and someone said, let's stop training radiologists. And here you see something interesting in the world of AI, but in general in latest technologies, which is technologies which work in principle, but not necessarily in practice. And here practice is clinical practice, which we know is very complex and dynamic. Or technologies and studies which prove interesting results in clean, highly controlled lab-based environments, but not necessarily in the dynamic and uncertain clinical practice. So where do we go from here? I think we have to go back to the basics. Just because we have an interesting technology and an impressive technology doesn't mean that we have just to stop everything we've learned for the last 3,000 years. And one of the key principles in medicine is the principle of non-maleficence, which is first, do no harm. In other words, before getting so obsessed with the cure, you have to ensure that the cure itself doesn't become the disease. In other words, before deploying something like AI as a powerful and useful technology, you want to ensure the technology itself doesn't become the problem. And here the problem at a massive global scale. And that's where we have to start with AI and ask the question, is AI safe for our health? What does it mean for AI to be safe in the first place? It's just a piece of software, zeros and ones. And that has been an interesting question I've been asking myself and others, trying to see whether someone can tell me what it means for AI to be safe. And here I offer you a definition of what I mean by AI safety, which is the absence of unacceptable risk of harm caused by the use of AI. Unlike any academic answer to a complex question, this answer has generated at least 7 more questions, right? Like, that's what I do to maintain my license as an academic. So I've done it at least for this talk for now. And possibly you're asking yourself what I meant by AI, use, caused, harm, risk, unacceptable, and absence, right? And I see these as the ingredients that will give us potentially an answer to a question as to whether a particular AI system that is being promoted as an answer to a disease or a treatment is safe or not. So let me take you through a journey of 7 ingredients in safety. But let's look at these in the context of healthcare specifically. And here you see I didn't say patient harm, because I want to explore harm beyond just whether it's just patients are harmed or it's more than that with AI. So let's start with what we mean by AI. Unfortunately, there isn't a consensus on the definition of what we mean by AI. And here's one definition, which I'm using because it's useful enough, from the National Institute of Standards and Technology in the US, which defines AI as the capability of a device to perform functions that are normally associated with human intelligence, such as reasoning, learning, and self-improvement. So the interesting thing about this definition, which is, I think, one of the best I was able to find, is it neither defines artificial nor intelligence. For artificial, it says it's a device. For intelligence, basically, it's telling us whatever you think human intelligence is. So it provides us with some reference points. And AI is like an umbrella term for many different technologies. One big branch in AI is called machine learning, and within machine learning, there's a field called deep learning, and within deep learning, there's one prominent technique called neural networks, or deep neural networks, or deep artificial neural networks. And basically, the way the technology works is the model, which is inspired by the brain, but not based on the human brain, it works by learning to perform certain tasks, generally without being specifically given rules to follow. So it infers these rules from the many thousands and millions of examples it sees. And it tries to adjust and the way it learns, it adjusts different weights within the connected layers of neurons to provide an answer. And the interesting thing about it, it seems to work. And there is this dilemma as to why specifically it works. But regardless, it seems to provide impressive results. The more data and computational power you throw it, the more impressive the results are. And as you know now, data and computational power are cheaper than ever. Hence why we have the latest revolution in AI. To give you an example, imagine I'm interested in developing a classifier for classifying whether chest X-ray images are showing pneumonia or not. All what I might need to do is give the system enough examples. By enough, I mean thousands, tens of thousands of examples where images with pneumonia and without. And after that, the system itself starts to learn what I mean by pneumonia versus the traditional approach where I need to draw what pneumonia looks like. And it's very, very hard because there are millions, if not more, than different ways in which pneumonia might reveal itself. So the interesting situation we have is we have a technology which works very well, but we don't know why exactly. And these two features are, on the one hand, great, on the other hand, are problematic from a safety point of view. And these two features are the underspecificity of purpose, and the other one is the opacity of the model, which I'll tell you a bit more in the next two slides. Let's start with purpose. Purpose is very important in proper engineering. Where imagine I'm developing a piece of software to include within a pacemaker. So the purpose here is very specific, which is help us regulate adequate heartbeat. Okay? And the way we do it in proper engineering is we have some equations and rules which we specify at a fine degree of detail. Okay? And then what we do next, let's see whether this technology works. Oh yeah, it works. We create a set of requirements, very detailed, telling the developers to develop the systems accordingly. And what we do is we take these requirements, we convert them to detailed requirements, create the design, the code in something like Ada, C, or God forbid, Python. And then we generate the executable object code, which is the zeros and ones that we have to deploy on the machine itself, ultimately. But importantly is what happens next. If you talk to safety critical engineers, they tell you, well, this is easy. This is the hard bit, which is doing checking and verification and validation that the software, this thing, is meeting our requirements, what we want it to do, and doesn't do anything else. Showing that the software doesn't do anything else, that's harder than showing that it does what you want it to do. So think about unintended behavior. So that's what we do in proper software engineering. So let's move to the world of AI now. So here, what we have in AI, we've stretched the intent. So we're no more telling the software to do something specific, but we're telling the software to diagnose pneumonia and offer treatments and figure out what happens in between. And this means that to capture the intent in specification, that's compromised because it's very hard to specify. That's why we didn't do it in the past. But at the same time, that's the power of the technology, to infer rules from data. And rather than having this proper engineering process, what we have typically in AI is this. It's a black box. We don't know what's going on, yet it seems to work. You see like the dilemma here. And actually, I'm not telling the whole truth. If you look at the model, it looks something like this, which is still many people don't understand what's going on, especially when we're talking about thousands of layers. So this is a very simplified model. And even the developers of the technology itself, they struggle to tell you what's going on. They know what's going on, but why things are happening, that's the big dilemma. Okay, so that's the first ingredient, what AI is, and why, in particular, we're concerned about it, but equally excited about it. Next is use, how it is used. And here we're exploring use in terms of clinical contexts. And let me explore it in terms of two dimensions. There are many dimensions to context. I'll explore it first through the technological dimension, the technology context, where these zeros and ones are going to live. And I'll do it via one clinical discipline, pathology, in particular histopathology, where a pathologist examines a biopsy after a specimen has been processed through a long process until you see it as an image, as a whole slide image. And we have a project with Oxford on evaluating one technique from Page AI for diagnosing prostate cancer, which uses AI. And the system is coming from Page AI that we are evaluating. And it is being trialed at the moment in the NHS. And here we have this very short demo thanks to colleagues at Page AI, in particular Margaret Horton, who recorded this demo just for this talk. So here we have an example of, imagine a pathologist examining an image of a tissue, and they can make a manual diagnosis, or they can go and seek the assistance of AI. And this is what happens here. The AI system, or algorithm, detected probability of cancer, and it tells you exactly where we have the highest probability of suspicion. And also, in addition to telling you what the potential diagnosis is, it gives you other information about the pattern of what it's seeing, its length, as well as the Gleason score, which helps with making the diagnosis itself. So that's an actual AI system, which is currently being trialed in the NHS and across the world and used elsewhere, which looks fine as a potential as a clinical decision support system. But the issue we find tricky from a safety point of view is this is what happens at the end. But the digital pathology pathway is very, very long and complex. And from a safety point of view, we are interested in whether any errors which occur, let's say, in tissue processing might propagate and influence the decision made by the AI itself. Because at the moment, a human pathologist would say, well, this doesn't look right. Okay? And the question is, will the system do the same? And here there are two ways to think about it. Either we do detailed analysis of everything that happens before and try to understand how things go wrong and propagate, or we do it the AI way, which is give the system more data. And the more data you give it, the more robust and resilient it might be against those variations. We don't know what the answer is, but these are two possible ways forward. The other thing to consider when it comes to the context is ultimately AI is going to be used by humans, okay? And you have to consider the extent to which the AI is supporting the human clinician in their clinical work and ultimately supporting their patients. So here we have a very, very interesting project funded by the MPS Foundation and led by Tom Lawton over there and my colleague Zoe Porter, who couldn't make it today, where we're examining different models of interaction between the AI system and the clinician. Let me take you through 3 different scenarios we're studying. The first one is what we call the dominant model or the standard model in the form of AI-based clinical decision support systems. And what we have here, does this work? Oh yeah, it works. we have the clinician acting on data which is electronic and not non-electronic, and doing the important task of talking to the patient, looking at the patient, and considering their, not just clinical data, but also their thoughts, constraints, and other matters before making a decision. And here you have AI system itself acting on electronics data and also making a recommendation. So on the face of it, it's fine. Okay, so basically this is a tool which is supporting a clinician. But now think about real clinical practice. Very busy people, okay, overstretched services, and you have an AI system which seems to work most of the time. And you know what might happen with something, and what might happen next, which is people might start suffering from automation bias and lack of situation awareness because you start relying more and more on the AI system. If the AI system works very well, we're all happy. If it fails, then some people might remind you that, well, the clinician is still there, okay? And it's still a clinically led service. And you know what they're saying? That just if everything works very well, then some people will get the benefits. If not, then there's still the clinician there. And a key hypothesis within this project is we're interested in understanding the risk of clinicians becoming liability sinks for AI. So that's the worry about this scenario. That's why we considered another scenario, saying it's the same, but rather than the AI system giving you a recommendation, a diagnosis, a treatment, here we say, let's give the clinician a basis for making a decision, useful data based on the AI system itself. And here, although the AI system has an answer, but we don't reveal it. So the clinician remains engaged in the process. So that's an alternative. The third option, although we have others, a year ago was very hypothetical, but now I think just it's what most people do, is we have 3 different dialogues happening at the same time. So first, the AI here is having a conversation with the patient, taking into account not just their electronic data, but their thoughts and context, because it's a conversational agent. The other dialogue remains very important between the clinician and the patient, and then finally there is a third dialogue between the AI itself and the clinician, trying to figure out what the right diagnosis or treatment is. So this arrangement is very similar to working as part of a clinical multidisciplinary team. So we're still evaluating these three different scenarios, and we're excited to see which one is going to come first, as it were, whatever first is. Okay, the most important thing here to remember, these are images, I imagine, of real hospitals, real clinicians. The main thing behind this is so it's a very busy and complex environment, and it's not this, okay? So this is the game of Go, which is a board game which is far more complex than chess, and where a few years ago, DeepMind in London ended up beating the world champion in AlphaGo, using AlphaGo, which is their software system, which is an impressive result, okay? But this is different from this. You see the difference, right? So this is a grid, a 19 by 19 grid. The boundary is well defined. Here, the boundary isn't defined. With this, the rules are defined. Here, the rules are rarely defined. That's why we talk about clinical guidelines rather than rules and standards. So that's what people have to keep in mind when it comes to what AI could do for our health. So don't just confuse this with the previous slide. So the third ingredient, causation, which is very, very hard. By causation, simplistically speaking, it refers to how the occurrence of certain things could contribute to the occurrence of other things. And causation and safety is a big thing because we are interested in understanding how certain failures or conditions could contribute to harm, risks, and hazards. And normally we see this as a simplified causal model, and that's how we try to model things. So, and here I'm going to explain this very simple model through an example. So here we have machine learning let's imagine as part of a wider clinical system. Let's say a system for detecting patients of high risk of developing diabetes. Okay, so we have machine learning here. I imagine machine learning fails through a false negative failure. In other words, it doesn't detect someone who's at high risk of diabetes. What this means that this will develop into a software failure, that within our software, this patient doesn't feature on the list, which means at the system level, the doctor is not going to see that patient on their screen, which means that there is a clinical hazard here, which is that the doctor is not going to intervene and offer treatment or something like this. Which might mean that this will develop further into the patient suffering complications and having to be admitted to hospital. Okay? So what we do in safety, and what happens at the moment in healthcare, is you develop many lines of defense. Okay, so in engineering, we talk about redundancy and diversity in order to stop this happening, propagating. And in healthcare, people talk about checks and balances, people checking things over and over. And if you talk to many clinical colleagues, they would tell you, well, errors are common sometimes in hospitals, but harm isn't, because we have too many checks. Okay? So we make mistakes, but we know how to stop them propagating into harm. And the question is with AI is not to make the mistake of thinking that AI is the answer and forgetting about these timeless principles. Okay, now we're hitting the core of safety issues, which is harm itself. So what do you mean by harm? And what kinds of harm are of interest to us? Let's start with the basics. Just because we have AI doesn't mean that we have to change AI guidelines on what harm is. So this is the way the NHS grades different levels of harm. Okay? And I think we don't need to change anything to do with accidental, physical, and psychological harm the way we look at it in clinical practice, just because we have AI now. But there are no different mechanisms by which we can end up with physical and psychological harm. And I'm not going to explore all of them, but let me start with some of the most worrying one, if you like, which is the risk of bias and discrimination being embedded into AI systems and potentially leading to physical and psychological harm. And here I have two examples from two different studies. The first one is from a leading journal in healthcare and clinical medicine, which is the New England Journal of Medicine. I can read it on the screen, which reported 3 years ago, nothing to do with AI, racial bias in pulse oximetry measurement. So basically the pulse oximeters, which measure blood oxygen levels. So very allegedly basic sensor. But based on two cohorts here, it reported that black patients had nearly 3 times the frequency of occult hypoxemia that was not detected by pulse oximetry as white patients. And now you can imagine a situation where we start using a sensor like this as an input to AI systems. So these would be the eyes and ears of AI systems. And if that's biased, then the output will likely be biased. Another source of concern here is the data itself. Because if the data itself also is, the data we use to train these models is biased, then the models themselves will be biased as well. But the problem here is that they're going to be biased at the national, global level, and it's harder for us to detect this. Because remember, these are opaque models. And here we have another study or review from the world of dermatology, where human dermatologists now find it harder to detect or to treat and diagnose diseases where they're dealing with people with darker skins. So the data itself, which is labeled by those humans, already problematic, and that's the data we're using potentially for treating these models. And here this study reports what we already know, that previously developed dermatology AI algorithms perform worse on dark skin tones and uncommon diseases. There are other social reasons why we have this problem already in the data, one of which is many AI models are trained on data acquired from private healthcare, where again, that data doesn't represent the wider population. So many other reasons for why we have that situation. A third kind of harm is when AI systems could undermine the healthcare service itself and basically sometimes a big region served through the NHS. And here, as promised, we have the Sunday Times. It's not all the Guardian. So here we have an example from a system called GP at Hand, which was developed by a company called Bubble in Health, which was supposed to offer allegedly AI-based apps and services to help with GP services across different regions, which is, on the face of it, it's a good idea, but in reality, what this meant was that healthier, younger patients want to use the tool, and older, more complex patients went with the usual service. And here we have a report from the Sunday Times in October saying that surgeries that lost patients to Babylon would often be left with those who were older and more frequently ill. This meant that if I'm a GP and have to deal with 20 patients a day, now those 20 patients are all complex potentially versus 20 patients which were of different criticality. And by the way, Babylon Health went bust earlier this year. It was at Babylon Health offices when Matt Hancock announced the next AI revolution in the healthcare. And as you know, he's gone as well. So the last kind of harm I'm interested in exploring is harm to the carers themselves, doctors and nurses and others. And here we can flip this kind of harm outside and think about it in terms of how can we support clinicians and preserve their human autonomy and judgment. And here I'm pleased to, by a collaboration we have with colleagues from Euphonia, two of whom are here, where we're evaluating the ethical acceptability of deploying AI in complex environments and try to explore different angles in terms of the benefits as well as how we can mitigate the risk through the design. So colleagues at Euphonia are developing an AI-based system called Dora, which is an AI-enabled voice agent for post-operative follow-up. And the idea behind it is that the AI system would call patients, say, following surgery, asks a number of questions, and then advise clinicians on next steps. So you've already seen AI with Page AI. Now let's hear AI. Thanks to a demo again from colleagues at Euphonia, in particular Ernest Lim. So that's a Dora conversation.
Good afternoon. This is Dora, the automated assistant from Stoke Mandeville Hospital. Is this Mr. John Smith speaking?
Yes, it is.
Hi, I'm calling to follow up after your cataract surgery. Would this be a good time to talk?
Yes, that's fine.
So, I've just got a few simple questions about your eye. Has your vision improved as you expected since the surgery?
Yes, my vision has got a lot better and I'm happy with the surgery.
Good. And since the operation, have you had an increase in floaters, small dark dots, squiggly lines or cobwebs in your vision?
Perhaps just one or two floaters, yes.
And these floaters, are they new since the surgery?
Yes, they started a couple of days after the surgery.
Could you tell me more about the floaters and when they...
Okay, that's AI speaking. So what did we do as part of this study? So as I said, we tried to create not just a safety case for the AI system, but what we call an ethics case for it. And we're going beyond just safety, but taking into account other considerations. And the important thing here is we're doing this now, so these considerations are weaved into the design of AI, rather than something we think about later on. So two perspectives here I'll share with you. There are many others. Is basically we're interested in the impact of AI on professional competence as well as psychological well-being. So the good thing about a tool such as this is that it is dealing with high volume, low risk, repetitive tasks where machines are good with this. And therefore, it's giving doctors more time with their patients, working at the top of their license, but also better access to patient data. But through a conversation with junior doctors in particular, who are co-authors on this study from Euphonia, they revealed to us something I didn't know before, that some junior doctors appreciate these calls because it improves their communication skills. And this means that when we are thinking about the deployment of a tool like this, we have to advise hospitals that to compensate for this, either leave some calls for junior doctors to make or give them an alternative way of gaining these skills. But again, we wouldn't be able to do this unless we had this extensive study. And this is important. Let's go back to our causal model because we have to keep the clinicians in mind all the time because the clinicians are a very important line of defense. We can't weaken their role when we deploy AI. Otherwise, we're losing one of the most important risk control in the process. Second ingredient, the next ingredient is risk, because we rarely talk about harm in absolute terms. We have to see it through the lens of risk. And we have some text from the Health and Safety Executive, so I had to go back to one of the excellent documents I've ever published called Reducing Risks, Protecting People, just to get an informal definition based on some legal text of risk, which is in this case the idea about possibility of danger. Or more technically speaking, risk is very simple, which is the product of severity and likelihood of harm. But it's at the same time very, very hard, because you have to agree on what the likelihood is and what the severity is. So that's the hard bit. But also it's important to distinguish between risk as assessed versus risk by experts based on data, and risk as perceived by those affected by it. Because we already know we all have our cognitive biases, and we tend, for example, to overestimate risks where the outcome, potential worst-case outcome, has some dreadful effects. Nuclear technology, falling off the sky, and things like this. So we end up overestimating the risk. And when it comes to AI, it's an interesting dilemma we have, because when I say AI, generally, people will remember the Terminator movies and say, we don't want to be killed by something like this. While in reality, if you carry your phone, it has far more AI than that movie. Great movie, very good movie, a long time ago. So let's look here how we can deal with risk as early as possible. So we consider it during the design of the system rather than after the fact. And here we have an exemplary study, I feel, which we did here in York, led by Yan Jia, whom I was fortunate to supervise as a PhD student with Tom Lawton, where here we looked at the use of AI to optimize the treatment of sepsis in intensive care. And here the objective wasn't to see whether this is a good idea, but to understand how this could be done safely by considering risk at the start of the process. So what we did here was to borrow an existing model, which was presented as an optimal model for treating sepsis, which is a life-threatening reaction to infection, using one of two interventions or treatments, either IV fluids or vasopressor. And vasopressor is a more powerful intervention than IV fluids. And here what we did was to take that model, which is already published, a deep reinforcement learning model, and try to understand how safe or unsafe it is versus a number of clinical risks of interest to us. And the most interesting one to us was the risk of sudden change of vasopressor dose. In other words, fluctuation in doses between two different administration of the medication, which is, to human clinicians, it's like, why would anyone do this under extreme circumstances? So here what we did was to look at the test data and infer something we have a reservation over it, but called the clinician policy, which is what the data tells us about what clinicians do in terms of how often do they administer something like this. Then we looked at the original policy, which is the published model, to see how often it exhibited that behavior or that recommendation. And it turned out that the average clinician who doesn't exist, does it 3% of the times, and for the original policy, the AI model, 35% of the time. And obviously you look at this and say, well, it's just too high, I'm not going to accept this. So what we did was, like any good engineering research, just try to mitigate that risk. And what we did here was to retrain the model and nudge it away from that behavior. In other words, rather than rely on the data itself telling the model what it needs to do, here we nudged it away from it. In other words, we penalized the model if it exhibited that behavior. And what we ended up was with 8% of the cases with that behavior. And the question for us was, is it good enough? Is that low enough probability? Would we accept it given that it's just a clinical decision support system, or should we try harder? But that's the kind of discussion you want to have between engineers and clinicians to decide whether that's good enough, low enough, but also to raise issues about even basic things like, do we agree that that's a good reference point or not? Or are we just imagining things? The other thing to say here is, for us to reach that stage and identify these clinical clinical hazards, it was a lot of work in terms of doing hazard analysis, risk assessment, creating a safety case, mapping the pathway, which required a lot of patience and humility in terms of just have to think hard about the problem. And these are two virtues which seem to be underestimated in the Silicon Valley area. So you have to just work hard on these things. Okay, when I say risk, someone would say, okay, what's acceptable risk? Or, more importantly here, in my definition, is unacceptable. And as you know, unacceptable risk, when I say it, someone might now be thinking of unacceptable to whom? And also, given what else? Because we say safety first, fine. What's second, third, and fourth? And do we need to do trade-offs between these things? Okay? And therefore, what we're saying here is the obvious, which is risk acceptability is a social construct. It's not a number I can give you. It's a process where we all come together and agree on what we deem collectively as acceptable and what reservations exist. And what we ended up doing here through a paper and a study between two safety engineers and two philosophers is create what we called an ethics acceptability case to reason about safety and other things, but within a wider framework of ethical acceptability. Because safety is one of a number of principles, not the only one. It's first, you might say, but there are other things. And part of this framework, which depends or which builds on the 4 ethical principles in medicine: beneficence, do good; non-maleficence, do no harm; respect for personal autonomy and justice. We use these as principles to guide making a decision about what is acceptable. And here I'll share with you one argument, structured argument within our framework, where the claim we're making about the just deployment of technology is as follows, which is that the distribution of benefit and tolerable residual risk and tolerable constraint on human autonomy is equitable across all affected stakeholders. So now we're bringing all people affected together to think about what is acceptable. But that's a very complex argument where we have to make further claims and further arguments. So and that claim hinges on other arguments, the first of which has a claim which says that the use of system benefits the group of beneficiaries. In other words, before proceeding, you have to tell me about what kinds of benefits are you promoting, and also, importantly, who is benefiting from those. So we have benefits. The second claim of concern is the usual safety claim, which is that the use of the system, AI system in this particular case, does not cause unjustified harm to groups of risk exposed. Again, we're saying classifying the kinds of risks of concern, but also who is the risk exposed here. We're not talking about the general average person, because it doesn't exist. The third claim of interest is that the use of system does not unduly constrain the human autonomy of groups of autonomy risk exposed. So, and once we have these 3 different important claims, we start, if you like, dealing with the most difficult part of the argument, which is trade-offs. Okay? And the first claim we want to be able to support is that the problematic role combinations of benefits, risks, and autonomy constraint across all affected stakeholders have been eliminated. So what do I mean by this? I mean examples such as groups of people who only receive risk but receive no benefits. And here I would say, well, this is not acceptable. Therefore, as part of the design of the system, we're eliminating these combinations from the start. The other claim of interest to us is that the distribution of these does not entrench existing inequalities across all affected stakeholders. And the final claim is trade-offs within and between and distribution of these issues are reasoned over in a reflective equilibrium procedure. So what do I mean by this? I mean, once we were able to reduce the risk as much as we can and maximize the benefits as much as we can we bring all of these affected stakeholders to a hypothetical room where we can see whether we can improve things further or rebalance certain things, until a point where no one could reasonably object to the use of the system. So this might be very hard, but if you think about what institutes like the National Institute for Clinical excellence does, that's what it tried to do, which is bring all people together, different experts, patients, to see whether we should fund certain treatments or not. And we should do something similar at a grander scale for AI. Okay, the final ingredient is absence. And as you know, showing nothing is very hard. So absence is very hard to substantiate. And therefore, the question here could be, how confident are we about the absence of unacceptable risk? And you can see the language here in safety, which is, everything is almost a negation of something else. And it's about a question of confidence. How confident are we about that? The absence of all of these things that we want to avoid. And basically what I'm saying here, or what I'd like to say is, that's a grand claim that we want to advance at the end of the process and be able to share with everyone our justifications, reasoning, as well as arguments and assumptions that we've made, and how and the extent to which they are supported by evidence. And basically what I'm saying here is we want to make the AI safety case explicit rather than keep it implicit, where if you now go and ask the big players in industry and beyond where their safety case is, good luck with that. And here you see that given the potential great benefits and risks, I think people are entitled to know what these key players are going to do with our data, with our health, and the future of many people. And speaking of people, that's good to conclude with the future. And as Paul already alluded to, I think the future lies in believing in saints. So Saints is a new center for doctor training we have here at York, which was announced earlier this year. It was one of 12 centers for doctoral training in AI, which were funded by the government, and York got the one which is almost exclusively focusing on safety of AI, because that's the place where safety of things happen. So we're very fortunate to have it, and it's a big investment by the government and other partners, a £16 million investment, fully funding 60 PhD students over 5 cohorts, 8 years, with 34 partners from industry, from government, from regulators, where the focus of the center is what we call, that's where the acronym comes from. So I don't know what you know in academia. We come up with the acronym and then fit it to something else. So the focus is on the lifelong safety assurance of AI-enabled autonomous systems. What do I mean by this? I mean safety, not just as something you do prior to deployment and you move on, but safety that you maintain through life, because the world is changing and the evidence needs to evolve for that. But also we're interested in the question of autonomy, to ensure that systems remain safe as we delegate more responsibilities from the human, accountable human, to the AI system. So that will keep us here busy for the next few years, but I hope we will be able to graduate people who will work in government, in industry, and beyond, to ensure that safety is taken seriously for the benefit of everyone rather than the few. And thank you for listening.
You said earlier that the success of AI probably relies on the data that you input. And it sounds like there's a vast amount of data being inputted. So how do you check that every piece of data is accurate? Because wouldn't it just take one single bit of data that's incorrect to cause sort of like a chaos theory? So how do you oversee all the data that's input?
There are two answers here. The first answer is, we have to check every single item of data to assess its impact. So that's what a safety person would tell you. It's too serious. the AI literature tells you don't worry about it. The big data will sort it out. In other words, any outliers will be masked by the fact that you have more data, and therefore that outliers will be dealt with through the large amount of data. So that's how AI researchers might answer it. And therefore, the right answer is to combine both, which is not rely totally on the system itself to learn to avoid the kinds of problems you have in mind, and do what we did with the sepsis work, which is try to nudge it in the right direction while equally ensuring that we have enough lines of defense, so if things go wrong, we still have some mitigation. But yeah, the answer is it's rarely that anyone will check every single item of data, because here we're talking about millions of items of data, so it's near impossible. And that's the dilemma we're finding, which is if we just rely on the data itself, then yeah, we can't guarantee that these kinds of behavior won't occur.
Hello, I'm a 78-year-old woman, and I find all this absolutely beyond my comprehension. However, there are three big queries that come up here. One is, we are all totally individual with multiply complex conditions, both mentally and physically, etc. And how on earth am I, my particular considerations, unless I voice them to this blooming thing that doesn't understand a word of what I'm saying anyway. Anyway, so that's the first thing. How on earth is that an unembodied thing going to understand me? Secondly, I hate being reduced to an impersonal piece of data which is going to be input into this blooming thing, which, and I don't have any control over it, and I'm relying on codes and algorithms beyond my comprehension. I'm giving my power away. I have no control over it anymore. And the third thing is, oh, here we go now. I was talking to an AI in a bank, and as soon as I was thinking about your chap who was answering questions on the follow-up, as soon as I stopped answering in very simple terms, and I said, well, absolutely, and so supposing he said, well, actually, I've just had a fall because I tripped over my rug and I've hit my head, and I don't know whether the floaters are actually anything to do with that or not. You've lost him. Okay, so there we are. Now, that's my thought for the day.
These are excellent questions, and these are research questions as far as we're concerned, in the sense that we want to advance good answers to those questions. So if you ask me, the answer is we need more research and slow down before we keep pushing with those technologies. But that's my answer as a researcher interested in the safe deployment of those systems which work for real humans whose data we're using. So that's what we're pushing for, and that's where this new center is going to advance its discussion, which is we bring everyone who is affected by the technology to the table, or people who are able to represent them. Otherwise, the danger is, as you said, treating each one of us as an item of data which we could use to train these models. And as far as one thing you said about personalization, and here you have two different answers. The AI-oriented people will tell you that's the power of the technology, which is to personalize and adapt to your needs, okay? Others would tell you, but that's very hard. What are you talking about? Have you used ChatGPT lately to see that really it doesn't do that? So, and that's where I think we have to keep testing those models before just believing in those claims with little evidence.
Can I just say that you'll have to wait for us to die off. And then you've got your kids and everything all doing, and so you'll just have to wait a bit and just leave us with some human beings to treat us until we've had our, sell-by date.
Fascinating talk, thank you very much. Richie Gale from HIMSS. I got particularly interested in macular degeneration and binary classification with convolutional networks, particularly integrating into a clinical care pathway. So I was really interested in your black box and mitigation. As a safety expert or as a potential as a regulator, what would be the most important? Is it the explainability of the algorithm, or would it be perhaps the evidence that it works in the population it's due to be employed on?
Okay, I'll give you the candid answer, which is it depends. So it depends on how critical the system is. So if we're talking about low criticality system, okay, where the human clinician is empowered and understands at least how the system works, not to say every single decision, then yeah, we can cope with systems with our black boxes. So low criticality, the patient and the doctor is empowered. However, I can't see this being accepted for something like, let's say, a pacemaker, where you deploy something like this into your heart and accept it as just it has great performance. So the answer will depend back to one of my last slides, which is the safety case itself. The context, how critical the system is, and what kind of evidence you have. But it's very hard to see it, at least in the near future, that would accept ultra-reliable safety critical systems where we don't know what's going on. To give you an example why this is, I don't think this should happen. Because at the moment, think about systems in healthcare which are like pacemakers or in aviation, where the auditors would come and look at the different artifacts that you have. And sometimes they go to the source code and ask you, what is this doing there? Like line of code you have. And if you don't know why it is there, you failed the audit because you lost traceability. And that's an issue we face here for ultra-reliable software systems that we need in operation. So it depends, I think, on the level of criticality and the role of the human clinician there.
So I actually started thinking about this question after listening to the lady in the front talking about, you know, losing the AI after, you know, presenting a slightly complex answer, and makes me think, well, some people might not want to interact with AI in a clinical context. They might not want to have a conversation with this AI. So I was just wondering how, like, patient consent comes into this question of using AI clinically?
Yes, so the answer is patient consent is necessary, but the issue is it happening in practice? Okay, so in other words, has anyone consented us that now a new American company has access to a lot of NHS data, which it is using to protect, as it were. So we don't individually get to consent this. But even things can be worse, not worse. Another source of concern to us is whether doctors themselves consented to the use of these systems as part of their practice. So imagine I'm a doctor. Do I have the option now to say, well, I don't want to use this AI-supported system on my patients? And that's another important question. So the answer is, yeah, I should be able to do it. In the same way sometimes I'm able to do this for other services. But in reality, that's the important thing, is we don't know what is happening in many cases. And that's when some people have concerns about AI going rogue, where many people start using it in different places, saying, well, it's fine here, it's fine there, and then we lose some control over it. Not necessarily we're all going to go extinct and die, but it's hard to bring it back, if you like, under our control. So yeah, these are open questions. We know what, in theory, the answer is, but the question is, what is happening in practice? We don't know, or possibly we don't.
Time for one or two more questions. I've seen one right at the back, please.
Thank you, Ibrahim. You say about AI going rogue, you very much showed how complex hospitals are. So it's one thing to say these things are going to be safe when we put them out there. How are we going to make sure they stay safe?
Yes.
I didn't wonder whether I should ask Colin.
Yeah, no, I think that's a very good question. That's why increasingly we talk about safety cases being dynamic. In other words, we don't just provide the evidence and just move on to the next project. We have a duty to keep updating the evidence to see whether the evidence that the system is safe and works continues to be valid as the world around us change. But also, once you deploy the system, people will change their behavior, and therefore your evidence is challenged. That's why safety is an ongoing business rather than something you do and you move on. It's not a certificate you get, but something you have to look after because of what we call the epistemic uncertainty in the world. In other words, deficits and problems with our understanding of the world rather than necessarily the technology itself.
Take the last couple of questions that I saw.
Hello. This was my first introduction to AI being used clinically, and I just wanted to ask, how can AI overcome the discriminatory aspects of the data? For instance, there's lack of data on pregnancy or the dermatology on black patients or colored patients. So how can AI overcome these aspects?
That's a very good question. The answer is it won't, because it's just an artificial agent. The problem isn't with AI. The problem is with the people, in some cases, developing those systems without paying enough attention to where the data comes from.
So its use is limited.
Sorry?
So is the use therefore limited?
No, it's not. No, I think it's a problem we can solve, but the starting point isn't the AI, because you can't blame the AI for these issues. You have to go back to people who curated the data, chose the data, looked after the data, and ensured the data was balanced and representative before using it to develop those systems. And therefore, we have to work not just on AI just a piece of software, but the people who decided to deploy it and develop it in that particular way. So go back to data, but data isn't the answer, it's just people who decided on the data itself.
That makes sense. Thank you.
Thank you. So it's very much related to the last question, but one about once the AI is out there, and you were talking about continuing to collect evidence. And it's related to the training and biased populations. So when they're out there, they may well be in, let's say, differently racially biased populations. So you've got different systems modifying themselves in a different way because of where they're being used. How do you manage that? Because they're becoming different, but they're not becoming worse. Okay. So I'm interested to how we will be able to manage that kind of thing.
Okay, that's within the scope of science, which is through life safety or lifelong safety assurance, which is what happens next after we deploy in many cases. And if you look at current practices in safety critical industries, many would tell you, even here in the audience, that's the hardest bit, which is maintain safety of systems. Think about aircraft, which is when Boeing sells you an aircraft, that's when hard work starts in terms of maintaining it, checking operational data, adapting the systems accordingly. And that's what we have to do with AI, but at a faster pace. Because as you said, people around it are going to change. And at the moment, there aren't many online AI systems which change online, if you like. Most of those systems are locked and deployed. But there is an element of retraining once, again, the world changes. And after retraining, you want to ensure that the evidence continues to be valid. So that's what I said, that safety doesn't stop on deploying, but once you deploy. But the problem isn't there. It's the problem, in many cases, the culture. So in safety, we say safety first, or cure is better than prevention. That's important. But the culture in many AI sectors is move fast and break things. And that's where tensions start to happen between a world which wants to move fast and just sell and move on, while the world of safety, you have patience, which is let's go step by step, collect data and adjust accordingly. And that's what we're trying to promote within our research here, within the Center for Assuring Autonomy and Science. But this remains an open research question as to whether existing techniques are good enough to deal with the pace of change and the nature of change exhibited by AI and people around it.
Thank you, everyone, for your questions. Really interesting debate happening, and we're at time now. So I'll say thank you all of you for coming out on this rather hot evening. I hope you really enjoyed talks, and of course, many thanks to Ibrahim for really engaging in a thoroughly fascinating talk. Thank you very much.
Thank you. Is it cold? It's not cold.